Hello everyone. So today we shall have a quick 3 minutes video about this type of eczema. Sometimes actually people make a very long diagnosis, or they actually after to make a diagnosis because it's a bit confusing. And this is what we call the disseminated eczema, or what we call auto-sensitization. So oftentimes you see patients who get maybe allergic contact dermatitis or a stasis dermatitis are getting lesions that actually look eczematous, and they go beyond the border of that lesion that you're seeing. So oftentimes people maybe think that maybe there's something else occurring at the same time, but this is just autosensitization that we expect. So in different literature, this disseminated eczema has been given different names, and this is actually shows you how people have been understanding it from different times. So it has also been called autosensitization dermatitis, or even auto-eczematization, or even generalized eczema. Some people call it the aid reaction eczema. So oftentimes it is secondary to a different type of eczema. Maybe you have a localized irritant contact dermatitis, then you get disseminated eczematous lesions, or even sometimes even generalized. You can even see it in atopic dermatitis. Maybe someone has fracture lesions, then all over the body they have these minute eczematous papules, which sometimes can be scaly or even edematous. So this is what we call the generalized or disseminated eczema. So commonly we see it in patients who get allergic contact dermatitis, and it will go beyond the site of where the allergen came into contact with the body. And then other forms also have also been seen in other infections, where you see things like severe tinea pedis, where you get a id reaction following tinea pedis or even tinea corporis, and then you get other minute discrete edematous papules, sometimes scale, sometimes edematous. So that is what we call aid reaction or auto-sensitization. So the key features in this type of eczema is that these lesions will appear a few days to weeks after the primary lesion. So meaning that someone will have the primary lesion well localized in the area, then a few days or a few weeks after, then they get these disseminated rashes that can cover the entire body. And they're oftentimes symmetrical, covering body sides, maybe if it is extremities, left and right, if it is a trunk, almost all sides of the trunk affected. And oftentimes it can also be near the area where you have the primary rash or the primary skin condition. And in the differentials, you can have other things to think about, like atopic dermatitis, which can also present in a disseminated pattern. And you can also think about other eczematous conditions like pityriasis rosea that can cover actually the entire body. So when you look at how common is this condition, so you find that 2/3 of patients with contact dermatitis can actually have it being associated with id reaction, as well as patients with stasis dermatitis can also develop this type of eczema. So the incidence is a little bit lower in other types of eczemas, but you see it more commonly in contact and also in stasis dermatitis. So every time you have a patient you're suspecting contact, just know that 2/3 of them can end up with an id reaction that can cover the entire body. And that actually should be very key for you to remember, because oftentimes if you have to make the diagnosis of maybe allergic contact dermatitis, because you see that maybe the rash is here, but at the same time this person has a generalized papillate, maybe a papilla rash that is eczematous. So if you have to make the diagnosis, but you can actually make the diagnosis because just that condition can get disseminated eczema. So in the clinical picture, we can see moderate to poorly demarcated patches of eczema, primarily on the extremities, and then can also appear on the face, or less commonly even on the trunk. Lesions can vary in size and number. Oftentimes they can be excoriated since they are pruritic, or since they are itchy, or sometimes they can be discrete papules. In other types of eczema, like in seborrheic and acidotic eczema, the morphology can differ and can be a little bit harder to distinguish. So this is what we are talking about. For example, someone had maybe a reaction here to muco, which is in the belt, and then they get this discrete, minute erythematous papules, which are distant. from the area where you had the lesion. Sometimes they can also be on the trunk. The way you see these ones, excoriated eczematous papules on the rest of the body. But when the initial lesion was on another location, so this is where the initial contact was, but then they get this discrete, widespread lesions that can be distant from where the initial lesion is. So this is what we call a reaction or disseminated eczema. So in the pathology, if you take off a sample still in the histology, if it is acute, you will see the features of acute spongiosis or a spongiotic form of dermatitis. And in the differentials, you can think about other things like atopic dermatitis, airborne contact dermatitis, even textile-related dermatitis. Sometimes even photoallergic dermatitis can give you a similar picture, as well as eczematous drug eruptions, especially the calcium channel blockers can give you a picture. They can look like an aid reaction. So you can also think about the mycosis fungoides as well as the Sézary syndrome that can also give you erythroderma. So in the main treatment, in this case, because it's an eczematous condition, the mainstream treatment usually give topical corticosteroids, and sometimes if it is itchy, you can add on systemic antihistamines. But systemic corticosteroids can also be given, but for a short time, in case need is there. Maybe it is so severe, so acute, and someone is not having peace, you can give a short course, systemic corticosteroids. So, but in prevention, you have to make sure you identify the initial cause. If it's an allergic contact, you identify what allergen the person is reacting to. Then you can now go ahead and what? Avoid it or treat the allergic contact. Then this other reaction will disappear. So thank you very much. This was a very short one. I'll see you in the next video. Remember to subscribe, share, and comment such that we push this video further to other end users.